how, okay, how we represent the statistics of a clinical trial. So, and then that will lead us into how we can simulate large clinical trials within our hypertension model. Specifically, we'll be looking at a case study of the ALHAT trial and how we can use these simulations of this trial to inform better decisions for any future trial design. So in this case, we'll be specifically looking at this diversity that we have in virtual patients and be able to perhaps identify what patients would respond best to certain therapies versus another, as the ALHAT in general showed a pretty much similar response to therapy in all of its arms. So let's take a step back a bit. First of all, we'll look at how Intelliza creates our modeling here. We use kind of a unique top-down approach, which is really what we're really focused on is capturing the clinical outcomes. Those are the top-level measurements that really can impact your decision-making processes. So things like, blood pressure and cholesterol levels, those very measurable outputs that you would measure in the clinic. Those are what we're really focused on to calibrate our model to. So we start with that, and then in order to do this, we go one level down to include the representation of the physiology that's necessary. So make sure we only put in the detail that's necessary in order to recreate the clinical outcomes of interest. And then, again, only as necessary, we go another level down to the key regulatory mediators that are needed to reproduce the outputs. So those would be things like the biochemistry and, certain biomarkers that you would want to follow. So in this model, our hypertension model, I'm going to give some examples of what the approach we took to create this platform. So our main interest, for instance, was to predict changes in blood pressure and kidney function, or otherwise known as the GFR and albuminuria. Those are measures of kidney function. And we're interested in not only capturing those, but how they progress over time and how they respond to different therapeutic interventions. So that's the type of data that we want to make sure that our model captures and can be qualified with clinical data. So in order to do that, we've captured the major physiological systems necessary to represent the hypertension and chronic kidney disease phenotypes. So, for example, we look at the circulation and the blood flow and how the blood goes through the kidney and gets filtered through the nephron. So we look at these renal hemodynamics, but we also add in such processes as glomerular sclerosis, which is really the disease process that will affect these systems as well. Our next level down would then include such systems as the biochemistry of the renin angiotensin-aldosterone system, otherwise known as the RAS system, which we'll be talking about a little bit today. And other things such as hormones, sympathetic nervous activity, biomarkers, etc. So again, our purpose, though, is to represent only the detail necessary in order to capture the clinical outputs of interest that we're interested in. I'd also like to note that even if we don't have something in this now, let's say you might be interested in a different output that we don't have, we can always adjust the model in order to capture new biology and fit it into the existing platform in order to perhaps look at a new therapy with a different mechanism of action. Our models can always be expanded for those purposes. So I'll be talking a little bit about our virtual patients later, but overall I just wanted to mention that we do have virtual patients that capture different patient phenotypes within the model. So, or similarly, the same phenotype, but with different underlying disease mechanisms. So, for example, in this platform, we could have two patients with the same blood pressure. However, they may have different disease etiologies. So they'll have different levels of the cardiac output versus total peripheral resistance. So while they have the same blood pressure, their underlying mechanisms are different, and this unique combinations may give rise to differential response to different therapies. So I'd like to go over briefly what's included in our hypertension platform. This slide will kind of be the overview of everything that we have and how you can look at the model. In general, it's a mathematical model of the human circulatory system. So that's pictured on the right with all these functions interacting together to control systemic blood pressure. But it was really built to capture the pathophysiology of hypertension, chronic kidney disease, and heart failure. And so the model can not only predict long-term disease progression, but also the effect of therapies, of antihypertensive therapies. So ultimately, we've integrated a large amount of quantitative data from the public literature into this single framework of differential equations that represent the dynamics of circulation. So as I've mentioned, we can create a variety of phenotypes, and these are listed in the slide right now. And that includes essential hypertensives, diabetic nephropathy patients, and various heart failure phenotypes. We capture a lot of high-level clinical outputs of interest. That includes, of course, blood pressure, but cardiac function, such as ejection fraction, which is often measured in the clinic, and renal function, such as the glomerular filtration rate, or GFR, which we'll be talking about a lot today. We also have, various biomarkers of interest for the field. Again, now listed is the underlying biology that's represented within the model, and today we'll be going over a little bit more detail of the kidney physiology and the renal hemodynamics. And finally, on the right is all current standards of care that we have represented within the model, which include, of course, both RAS and non-RAS therapies. Here's a closer look at the therapies that we actually have represented. I just want to, highlight this a bit. It's also really important to note that we can simulate both mono and combination therapy regimens. And in general, we can follow the effects that therapies have in order of weeks and months and years down the road. The dynamics of these therapies are well represented within our platform. But I also do want to point out that we can always add in proprietary PK and PD data for our specific collaborators. They may have different needs. Again, the model can always be expanded to very easily accommodate any new biology or mechanisms of action that may be needed. So the whole hypertension model in general includes different modules of these physiology, and a lot of them are based on existing mathematical models that we started with and perhaps expanded from there. So the core would be our long-term blood pressure regulation, which is on the well-known and accepted Guyton model, which has the kidney regulating blood pressure. We've also have the representation of a nephron and GFR and albuminuria, but we've also expanded that to allow us to capture the dynamics of disease progression and response to therapies. So the cardiac function is also another part that's based on the heart cycle mechanics work by Bovendierd. And